I'm Dr. Obey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we have another great show for you tonight, and today we're going to talk about cervical cancer. It's a very, very important topic, and we're going to cover it from A to Z. So hold on, because we got a few things to cover before that. Don't forget, sharing and caring. Alrighty, make sure that you continue to email me, because that way I know what's going on out there, and I can continue to bring you the shows that are most important to you. You can go to obeyyourdoctor.com and email me. Just send me all that email and tell me what you, give me a testimony. Let me know what's happening so I can get back to you, or we can have that on the show. All righty. Well, second thing I'd like to do, I'd like to just sit back and talk to you just for a minute. Let's have a let's talk moment. I want to talk about heart failure. You know, when your heart just doesn't pump efficiently to get the blood out of the heart, to get it into the system, your whole body, such that oxygen is able to feed the body and the cells that need that oxygen so you can live appropriately. The heart is a major organ for us, and when that's not working properly, everything else is suffering. So we're going to talk about heart failure. Heart failure, let me read this just for a minute. Heart failure is a condition in which the heart is not able to pump enough blood to meet the needs of the rest of the body. Basic concept. If it's not pumping efficient and getting the blood out, we're not supplying the body with oxygen. So what causes heart failure? High blood pressure. If your blood pressure is high, then the heart is pumping against a high blood pressure to get that blood out into the system. Heart attacks. Heart attack is when part of the heart muscle is not, well, it can die. Even part of the heart muscle can die in a heart attack. That heart is not able to pump efficiently. Alcohol consumption. Alcohol, if you overdo alcohol, it makes the heart really flabby and it's not able to generate enough power with the muscle that it has. Infections. Infections can take a lot of the power out of the heart as well. And abnormal heart valves. If the heart valve is not closing at the right time, then the blood is not going forward in an appropriate manner to get the blood out into the rest of the body. And things like chemotherapy and surgery can affect the heart as well. Well, what are symptoms of heart failure? Well, of course, shortness of breath. Think about that. Coughing or swelling of your lower extremities or your feet. If your feet are swelling, it may be because the blood can't get back up to your heart appropriately, and the fluid or the liquid part of the blood is oozing out into the tissues. And these are some of the things that we must think about as far as heart failure is concerned. Well, I just wanted to give you that little tip before we started the major portion of our show. Well, let's talk about cervical cancer. Now, cervical cancer is a type of cancer that's very, very, very important as far as, you know, there's just so many females out there that come across, that has the potential to get cervical cancer. And we have the perfect person to talk about this particular disease. We have Dr. Patrick Anderson. And let me read this title now. He is chairman of OBGYN and director of GYN Oncology at Newark Beth Israel Medical Center. Dr. Anderson, welcome to our show.
Pleasure.
All righty. Well, this is a topic, and look at what we're doing here now. Look at what we have two males talking about a female problem, but we're going to get through this. We're going to get through it. We're going to do it, and we're going to do it well too. So let me ask you the first question. What I'd like to ask is our basic question: what is cervical cancer?
Well, cervical cancer is cancer that affects the mouth of the womb. The mouth of the womb is really the conduit between a woman's vagina and the womb. And while we may think cervical cancer is a woman's disease, like prostate cancer, cervical cancer is also a male disease, since we're now saying prostate cancer is always also a woman's disease because it impacts a woman's life, quality of life, which includes relationships and fertility. It's abnormal growth of abnormal cells in the mouth of the womb.
Okay, okay. Now, let's just give some structural understanding. And I know we're gentle with this subject because we're talking about female anatomy, but give me some understanding. The ovaries are here, the tubes come, then it's I think the uterus.
Correct.
The cervix, and then the vaginal vault.
Correct.
All right. So am I right? Go through that for me. How it looks and what we're talking about is the cervix and where the cervix actually is.
Okay. So when you describe the female genital tract, starting from the lower genital tract, the exterior, you have the vulva, which is what most people describe as the lips of the vagina. Then there's the vaginal vault. Then the vaginal vault, as you ascend, connects to the cervix, which is really the entryway into the womb or the uterus. In fact,
the uterus is where, if someone was pregnant, that's where the baby would be.
That is correct.
Okay, okay.
And in fact, in most anatomy books, the name of the cervix is actually uteri cervix.
Okay.
So it indicates the connection between the two anatomic regions.
All right then. So what we're talking about the entrance into the uterus.
Correct.
Where the uterus is.
That is
okay.
correct.
All right then. Now, is there a specific function for the uterus? What does it do?
Well, the function of the uterus is essentially to accommodate the fertilized ovum. And once
You're throwing these words at me, man. Fertilized ovum. Okay. Break that down for me. Okay. What are you talking?
So to break it down, when a woman and a man decides to have a child,
right,
and they have intercourse, the ovum is the egg. The sperm meets the egg.
Okay.
When that union occurs, it needs a safe, nurturing environment in order to develop into a fetus, which ultimately becomes a baby and ultimately becomes you and I. That kind and gentle environment is the womb. It's a smooth muscle organ.
Okay.
It's very muscular, very rich in blood supply. And physiologically, it's an interesting sequence of events that occur due to several hormonal changes when one becomes pregnant, where the muscle becomes thicker, the blood supply increases, the lining increases, all in an effort to support this fertilized ovum.
Okay. Now we're talking about cervical cancer, so does screening in some way help prevent or help us identify which patients or which female may be getting cancer or may be more prone to cancer?
Correct. You know, screening, the history of screening for cervical cancer is actually quite interesting. George Papanicolaou in the 1940s actually presented us with the Pap smear. Pap as in Papa Nicolaou smear. And interestingly, some of the research he actually did on his own wife. And prior to the introduction of the Pap smear, the incidence of cervical cancer borders about 30 to 40 per 100,000 women. With the introduction of the Pap smear, if you look at the graph, it gradually, actually quite exponentially, declined to where up until the early 90s, mid-90s, when we start to do another set of testing, which we'll talk about, got to around 8 per 100,000. And that's all due to screening using the Pap smear.
Right.
Now we should bear in mind the Pap smear has gone through its own evolution with respect to nomenclature, which means how it's classified based on the degree of abnormalities that are present. But a Pap smear is not a diagnostic test. It's a screening test.
All right, step back. When you say it's not a diagnostic test, diagnostic is a big word.
Correct.
What do we mean diagnostic?
It does not tell a woman that she actually has the cancer. What it does, it puts her in a risk category. It helps us stratify her risk.
Okay. So it allows us to say, this particular patient, I can rest assured that she does not have cancer because of the pap smear. This particular patient, there may be a chance because of the pap smear that we should do more tests and see if she does have cancer. Am I in the right ballpark?
The latter is true.
Okay.
A negative pap smear does not necessarily mean cancer does not exist, because
Gotcha.
there is a certain false negative rate.
Okay. So.
And again, when you look at the history of screening for cervical cancer, it's quite interesting. It's a model that actually parallels the way medicine developed. So we talk about the introduction of the pap smear and the decline in the rate of the cancer.
Right.
Now we have to struggle with a false negative rate, which early on, I've seen studies that report false negative rates that varies anywhere from 5 to 20%.
All right, I hate to stop you again, but I'm gonna be stopping you because you're up here. Okay. We got to talk false negative. All right, when you're saying false negative, you're saying that it's negative, but it showed a negative test, but it really could have been positive. It really may be positive.
That is correct.
That's what you're saying.
That is correct.
All right.
And during the time when, providers became concerned about false negative rates, a significant aspect was the human error. In the past, we used to do 2 smears, 2 glass smears. So if I may step back and just say to you how a pap smear is appropriately performed.
Okay, let's
The
go.
cervix has 2 types of covering. We have the endocervix, which is one type of cell, and the ectocervix, or outside of the cervix, which has another type of cell. Where they merge is called the transformation zone. And that's the vulnerable point, because one epithelium or covering constantly changes to the other. That area is a point of vulnerability for both infection and abnormal DNA formation. Yes? And that's an important area that has to be sampled during the performance of a pap smear. So while you'll see a pap smear being read as adequate for evaluation,
Right.
it needs to say endocervical, meaning the inside canal, and ectocervical, meaning the outside, are present. Now, in the past, we used to put a sample from the inside on one slide and a sample from the outside on another slide.
Right.
Now, a cytopathologist have to look at 2 slides.
That's the person who looks at the slide and determines whether it's normal cells or cancer cells.
That's correct,
Right.
or abnormal cells.
Right.
Now, because of the amount of slides and the time takes to read 2 slides for one patient, we thought that probably was one of the factors that contributed to some of the false negative rate. A portion of it could be also fatigue.
Right.
So then we went to put in both samples on one smear. So now that one smear has both the endo and the ectocervical cells on it.
Right.
Correct? Now, that helped to decrease the human error.
Okay.
Then subsequent to that, we moved to what we call liquid-based technology, which is instead of smearing the slide on the sample on a slide and spraying it with a fixative, it actually goes into a liquid that preserves the cells. That liquids allow you to dilute all contaminants. So the sample that actually gets evaluated is a pure sample. It has more cells than debris.
Right. I understand. How does someone present to your office that may have cervical cancer?
Well, actually, the majority of people, women with cervical cancer, are asymptomatic, meaning they have no symptoms. In fact, when one presents with symptoms, the disease is at present and probably advanced.
What are some of the symptoms that they may present with? Just to give me a
common
sample.
symptoms are vaginal discharge, bleeding after intercourse, after sexual intercourse, lower back or leg pain, or just irregular bleeding.
Okay, all righty. What about family history? If mom or grandmom had it, is it more likely for the future generations to get it?
Cervical cancer, the classic cervical cancer, which I may use a big term, squamous cell is the most common type, but there's also another type called adenocarcinoma, which develops in the glands. Glands are structures that make secretions like mucus. Those are typically not genetically based, as we know, passing from one family member to another.
Right.
However, theoretically, the real culprit in cervical cancer is actually the human papillomavirus.
Oh.
So there is viral genetics there. So intellectually, when you talk about genetics, you have to think of the human genetics or the viral genetics.
Right.
And there can be enclave of people that has the same viral genetics that leads to cervical cancer.
Right.
Now that speaks to, relationships and, who has relationships with who.
Right.
But that's, a subject for another day.
Right. Tell me about race. Is there a certain race that you find more prevalent in than others?
Well, like I said before, the main culprit is the human papillomavirus.
Okay.
Which is a double-strand DNA virus, and it has a predilection for primates, okay? So it likes human beings.
Right.
Now, it may appear that it's prevalent in certain races, in certain socioeconomic class, but actually the risk factors for the garden variety type squamous cell as it relates to the human papillomavirus is essentially the same across all
the board.
races. But there are certain risk factors that would make it seem more prevalent in certain races or certain groups of people.
What about as far as if it's found early, is that a good sign? Are we able to treat it better if we can find it early?
As in most cancers, if found in the early stages, it can be treated and cured. And intuitively, the earlier it's found, the more likely it is to be cured. Now, an early stage, a stage 1, and we can talk about stage, and it could become a cluttered conversation when we describe the stage, but essentially, stage 1 or is disease confined to the cervix itself.
Right.
Yes? And when you break down stage 1, it can be, pre-invasive, or some people call it stage 0, or stage 1 itself is broken down into a 1A, which in turn is broken down into a 1A1 or a 1A2.
Gotcha.
And that is it's based on certain physical parameters,
right.
measurements. But long and short of it is stage 1 is confined to the cervix.
Right.
Stage 2 is when it starts to spread onto the vagina, or a disease just parallel to the cervix, a little area, anatomic region called the parametrium. Stage 3 is when it's spread to the pelvic sidewall, and you can define that as if you put your hands on your hips and you feel the hip bones. If it gets out of that area, it's a stage 3B, or if it extends down to the up lower part of the vagina, it's a 3A. And then there's a stage 4. Stage 4 again is subdivided into a 4A. 4A is extension into certain adjacent structures like the bladder, the rectum. And a 4B if it gets into the lung or the liver. Right. So obviously, the farther along it is, the more likely it is that you won't be able to cure it. But the early stages, the cure rate is quite high. An early stage 1, a stage 0 or 1B or 1B1, the cure rate can be as high as 95% over 5 years. And when you look at it gets to a 3B, that cure rate's dropped to about 60 to 65%.
Okay. What about as far as if you get a pap smear on a regular basis, the likelihood of catching it and getting it at an early stage is it increased?
Well, again, this speaks to the history of the screening of cervical cancer, which I think, again, is fascinating. So now, where are we in 2014 with screening, right? So now we've gone from screening to diagnosis to actually prevention, okay? Because now we have a vaccine against the more virulent strains of the HPV virus, yes?
Oh, all right.
Not to use commercial terms, but it's a vaccine against the 4 major high-risk types. So now, when you do a cervical cancer screening or a pap test, right, what's recommended is actually to do HPV typing. In fact, some may argue that we may not need the conventional pap smear anymore, but an HPV typing alone may be sufficient, because we know that the high-risk HPV is in 95 to 98% of all invasive cervical cancer. Okay, and we must be so while we're talking about cervical cancer, this HPV also is implicated in vaginal cancer, cancer in the lips of the vagina, and in men and women, anal cancers, and even penile cancers.
Interesting.
So it's a virus that's, its influence is far-reaching.
Right. Can you have HPV or that particular papillomavirus, what a word, human papillomavirus, and not know it?
Oh, yeah. In fact, HPV is probably the most common sexually transmitted infection. And it's because of HPV, while cervix cancer is actually on the list of sexually transmitted diseases.
Interesting. All righty. Does what increases the chance for you to get HPV? I mean, multiple partners, or I'm cruising for Saturday night, that type of thing.
Right. Early sexual intercourse, onset of sexual intercourse, multiple partners.
Right.
Obviously, some patients who are immunocompromised, so probably patients with HIV disease, patients who are on immunosuppressive drugs for organ transplant, certain patients with certain autoimmune disorders can be at higher risk for acquiring HPV.
You're throwing these words out there. I love it. Autoimmune disorders. All right. That's like if your body's attacking itself.
Correct.
Or something like that.
Or you have, for lack of a better term, a lowered immune system.
So when you say immune system, usually that's the system that protects us from germs and bacteria and viruses and all of that. And if that's not working appropriately, then we're more prone to getting.
That is correct.
HPV. Okay.
That is correct.
All right. How do we get rid of it?
Well, HPV?
Yeah. Well, I want it gone, man.
As in most viruses, HPV, there is no antibiotics for HPV.
Okay.
Now, we can treat certain symptoms. For example, if you go to the end of the spectrum where there's cancer, the cancer can be treated by certain stages based on the stage, right? So early stage disease, we can treat with radical surgery or radiation and chemotherapy. And the two modalities in the early stages, actually the outcome is equivalent, okay? However, surgery does offer some fertility sparing approaches when indicated, all right? Now in advanced stages.
Fertility sparing, meaning that you can still bear children.
That is correct.
Gotcha.
That is correct. But in the advanced stages, radiation in combination with chemotherapy is a better treatment modality for patients who meet the criteria for having chemotherapy.
Okay. Can it be chronic? Even though you got treatment, it's just ongoing type of thing?
Well, can the cancer be chronic?
I mean,
or the HPV?
Oh, HPV.
Now, the HPV is interesting. It's a virus, and again, once you get the virus, there is no real way to get rid of the virus, except in someone whose immune system is really solid and working well. We know that 80% of women who acquire the HPV virus actually get rid of it on their own. But for the ones that persist, there's a sequelae or a spectrum of symptom that can occur that ranges from nothing to genital warts.
Right.
And we can treat the warts through various ablative techniques, such as essentially burning them off with laser or electricity, or certain topical medications.
Right.
Yes. But the majority of folks with the HPV virus is asymptomatic.
Interesting. When should you start getting pap smear tests?
Okay. Again, it takes a whole show to talk about the history.
I know. We're grabbing here.
Yeah,
we're grabbing.
yes,
I know we're doing a whole semester's course in
a few minutes.
In a few minutes, I understand.
That's correct. So now, recently the organizations that evaluate and make recommendations with respect to cervical cancer and lower genital tract disease. And some of the major ones include the American Society of Cervical Cytology and Pathology, Society, the American Boards of OBGYN.
Right.
You know, in the past, the woman would start or get her first pap smear when she starts having intercourse.
Right.
And the recommendation would be annual pap smear until you get to about 70 years old. Okay? Now, obviously, at that time, that schedule would change based on circumstances. If you have known HPV disease, or if you've had surgery for a pre-malignant or a malignant lesion. Now, the more recent recommendations is as follows. First pap at age 21. Okay? Now, at that time, all you do is a pap smear. Right. Don't do the HPV testing. Not yet. Okay? And if that pap is normal, then you can repeat it in 3 years. Not annually, but in 3 years.
Right.
Okay? Now, if there's any abnormality, and it's a low-grade abnormality, such as what we call atypical, it puts them in a low-risk group, then you can, quote-unquote, triage by doing the HPV testing.
Right.
Now, subsequent to that, you know, when a woman gets to be around 35 years old, the recommendation is to do both the cytology, which is looking at the cells, and do HPV typing.
Right.
If they're positive for the high-risk HPV,
right.
or if they're negative for the high-risk HPV and the cells are negative as well, then it's every 5 years.
Okay, we're gonna have to stop right there because the show is just about over, and I have to close out. But thank you for coming, boy. What a topic! We're gonna have to get you back and cover the other 75% that we missed.
Well, I just want to say to you, we really spoke more about screening and not the disease.
Not the disease, but we'll get it. In closing, remember, sharing and caring. So email me at obeyyourdoctor.com. Let me know what's going on out there. Never institute any change in your medical care until you consult your physician. I trust each and every one of you. Continued good health. I'm Dr. Obey, and this is A Moment in Medicine. Until next time, peace to you all.